Dr. Gail. So I think we have already more than 100 people online. I think we are ready to start. Please, Dr. Gail.
Okay, yes. Hello, good evening, everyone. I'm Dr. Gail Tra. I'm from the FARO Education and Training Committee. Thank you, everyone, for your attendance, and I'd like to welcome you all to the 13th FARO webinar on novel agents and techniques for prostate cancer. We've got 3 very interesting talks lined up for tonight, but before that, we've got Professor Yasushi Nagata, the Secretary General of FARO, here to give us the opening remarks. Dr. Nagata, please.
Thank you. Kind introduction. Good evening. I am Yasushi Nagata, and I work at Hiroshima University, Hiroshima, Japan. I'm also a member of the board of directors of JASTOR, Japanese Society for Radiation Oncology. I would like to thank all of you for my nomination as the new Secretary General of FARO. I'm honored to have an opportunity to promote radiotherapy throughout the Asian continent with all the members of FARO. In my career, I've been involved in the development of CT simulator at Kyoto University since 1988, and I also have been engaged in the development of SBRT, stereotactic body radiation therapy for lung cancer, since 1996. In the course of the development of from 3D conformal radiotherapy to SBRT, IMRT, and particle therapy, the high precision radiotherapy has been remarkably well organized. It is my expectation to introduce these technologies widely throughout Asia. Recently, I'm conducting a randomized clinical trial. In this trial, 2 radiation fraction regimens, 42 gray and 55 gray, are compared in 4 fractions in the treatment of early lung cancer named JCOG 1408. Throughout my experience, I strongly believe that clinical evidences enables us to enhance the promotion of radiotherapy in the field of cancer treatment, and multi-institutional clinical studies among Asian countries can play an important role to realize it. In Japan, the number of radiation oncologists are still in short. One of my missions is to increase the number of radiation oncologists, not only in Japan, but also in Asia. As many of you know, FARO was established to build strong relationships among national radiation oncology society across Asia, with the firm resolution to improve the healthcare for patients and cooperating with member societies in research, education, and clinical practice of radiation therapy. FARO currently consists of the national organizations from 14 Asian countries and has successfully hosted 5 scientific conferences in the Asian region. In this current situation, where a vast number of people from all over the world are suffering from COVID-19, it is necessary that radiation oncologists continue to confront these hard times to save our patients not only from cancer, but also from COVID-19. I'm sure we can cooperate to overcome this unexpected COVID-19 pandemic. Currently, the International Radiation Oncology Society, IROS, is under planning throughout the IAEA. FARO is set to be a member of the IROS to further promote radiation therapy even across the world. It is my expectation that FARO will continue to grow for many years to come. Let's make sure that we continue to stay connected and to stay strong. Today, I'm very happy to have made an opening remark at the FARO webinar. Thank you very much for your attention. Thank you.
Thank you, Dr. Nagata, for the opening remarks. And thank you all for joining us this evening. So first off, we actually have Dr. Jeffrey Chuan, who will be speaking on SBRT for early stage prostate cancers, and then followed by Dr. Melvin Chua, who will talk about the use of novel agents with prostate radiation. And finally, Dr. Ooi Kiat Huat will be speaking on brachytherapy for prostate cancers. Our moderator today will be Dr. Jeremy Tay. He's a senior consultant from the Department of Radiation Oncology at the National Cancer Institute of Singapore. Over to you, Dr. Tay.
Thanks, Wiao. Good evening, everyone. So our first speaker will be Dr. Jeffrey Tuan. Allow me to introduce Dr. Tuan. Dr. Tuan is a senior consultant radiation oncologist and head of department of the gastrointestinal, hepato, pancreatobiliary, and urology at the National Cancer Centre, Singapore, as well as research director of the division. His clinical interests are in urological and gynecological cancers using advanced radiation techniques such as IMRT, SBRT, and brachytherapy. His current research interests are in intrafractional tumor tracking, focal therapy in prostate cancer, and identifying potential biomarkers in radiation sensitivity. He has spent 4 years training and pursuing academic research in both the UK and Italy in the fields of clinical oncology and particle beam therapy, and as the technical lead, is actively involved in the planning and setting up of the new proton beam therapy center co-located at the National Cancer Centre, Singapore. And this will be ready in 2022, early 23. Today, Dr. Tuan will speak on SBRT for early stage prostate cancers, practical implementation steps and pitfalls. Dr. Tuan, please.
Okay, thank you, Jeremy, for the introduction. I'm just going to share my screen. So can everyone see my screen? I presume yes. So I'm going to talk about SBRT for early stage prostate cancer, the practical implementation steps and some of the pitfalls. Just going to move this out of the way. All right, so basically this is the outline of my talk, starting with a case study, a little bit about the NCC experience and also what to expect and what's new in 2022 actually now. So basically this slide talks about the NCCN guidelines. So as you can see over here, ultra hypofractionation is what is defined as SBRT. When we talk about using a dose between 6 to 8 grays, given between 5 to 7 fractions. And you can see that actually is indicated for NCCN risk group for prostate cancer, ranging from very low and low all the way to high and very high. Although actually in our initial experience, we have focused mainly on treating low to intermediate risk prostate cancer patients. And interestingly, they also define 6 times 6 gray as ultra hypofractionated treatment, as with the Stampede trial, which is indicated for low volume metastatic prostate cancer and having a survival benefit in those with low disease burden. So that kind of sets the stage of what is actually defined as SBRT, and that is using high dose per fractions to treat prostate cancer. So my example is basically this 80-year-old Chinese man. He has the usual comorbidities of heart disease, hyperlipidemia, hypertension, and so forth. His cancer actually was considered to be localized and low stage. PSA was 7.2, decent score was 7, 3+4, and on the MRI actually shows that there was cancer defined on one side of the prostate involving the posterior peripheral zone at the apex and mid gland. And there was no extra capsular extension seen on the MRI scan. So technically that puts him at a T1C. There was a CT scan done on the thorax, basically shows there's some subpleural scarring of the right lower lobe, probably was benign. Prostate biopsy returned as Gleason 3+4, 7 of 18 cores. The usual bone scan done, it's actually indicated no evidence of metastasis. And he also had a TUR-BNI done because he was also suffering with BPH, leading to obstructive symptoms. This is what the MRI and the bone scan shows us, and basically it shows that there is a localized cancer in the prostate, and the bone scan is free of distant metastasis. So what do we do when we talk about SBRT? So the steps and process involved is that we will then put the patient in for a CT simulation, and preferably using booking an MRI on the same day. The reason for doing that is that we want to set up the patient the same way with the same bladder and bowel preparation. If you can't get the MRI slot on the same day, we allow for maybe an MRI on the following day, one day after, due to sometimes difficult to get availability of the MRI scanner. So what we do for the bladder is that we want the patient to have a comfortably full bladder, and that's usually asking the patient to drink about 2 to 3 cups of water, and then waiting about 30 to 45 minutes. Patient usually also has rectal and bowel prep the night before with the Dokter suppository or oral, and then the feed enema actually on the day of the scan or the SBRT, the procedure itself. And typically that's about between 1 to 3 hours before the procedure. Immobilize the patient either with a back lock or a knee wedge, depending on your comfort in setting up the patients. I think with current experience, we realized that sometimes we can get away without using the back lock, and patients tend not to move too much as long as you keep them comfortable. All this is being done to allow us to reposition the patient reliably, consistently throughout the 5 treatment fractions in order to meet the tight constraints that we have. The usual dose that we give will range from about 36.25 to 40 gray in 5 fractions. We tend to use it, treat patients on EOD basis, which means every other day. Typically, in my case, I treat them on Mondays and Thursdays. It's also possible to treat them daily or even weekly. Our current dose that we use in NCC ranges from 36.25 to 37.5, and that's primarily for the low to intermediate risk groups. So example of what happens at the unit. So we set up the patient and then use CBCT to look at the bowel as well as the bladder filling. So typically, even before that, we used a trans-abdominal bladder scanner to estimate the bladder volume so that it will increase the throughput as well as the workflow of our patients. So we can see that it's a 3-dimensional volume, and the radiation therapists as well as the radiation oncologists will go through to make sure that the registration is good. Typically focusing on the region between the prostate and the rectum. You can see in this case, there is something in yellow here, and that actually will come by later on, and that is the rectal spacer that we have also started here in National Cancer Center. And these are the shifts that will be applied for this patient. We have a 6 degree of freedom couch. Therefore, we can apply translational as well as rotational corrections for every fraction before we actually deliver the radiation. We have also incorporated the use of fiducials, where up to 3 gold markers will be implanted into the prostate. And this allows us to do what is known as trigger imaging when as the gantry moves around the patient, snapshots can be taken to make sure that the fiducials are within zone. That's to minimize intrafractional shifts during the treatment itself. Even as we use FFF, which allows us to treat patients very quickly in a matter of less than 2 minutes, but I think we still find this useful to make sure that there's no potential drifts or sudden movements by the patient. After the patient has been treated, we monitor them for side effects, and this is an example of what we look at. So we look at ask the patient whether he's fatigued, whether he has any GI and GU toxicities, and typically these are recorded in our oncology information system. In our case, we use the Mosaic system by Elector. So just to go through some of the pitfalls. So of course, the first is to decide what sort of indications of prostate cancer that you want to treat for SBRT. Typically, although NCCN guideline states that you can treat patients across the risk group from low to high, I think that most of us will be a bit more comfortable starting with the low to intermediate risk groups patients. That will allow us to decide to omit androgen deprivation if possible, and that will be very useful in trying to look at the response after treatment and minimize the long-term toxicities of hormone deprivation. If a patient has very large prostate volume or have symptoms of acute retention, then these patients may not be suitable, as prostate tends to swell up after these large treatment fractions. Alternatively, you can send them to the urologist to do a TURP to relieve this obstruction and avoid the need for insertion of catheter during the SBRT itself. whether or not a patient requires treatment to the pelvic fields. So although it is possible to treat pelvic fields in 5 fractions, but it's not commonly done, and we're a bit worried about toxicity of large dose per fractions, but something to consider. And the use of FFF will allow us to treat patients much quicker. So when we had to treat patients over 10 to 15 minutes, now we can shorten it to about less than 2 minutes. And it's the importance of rectal and bladder preparation, and this has to be conveyed to the patient. A little bit of a bit of a hassle. Then you come earlier, but that will still be a lot shorter than having to go through 8 weeks of conventional fractionated radiation treatment. And if there are metal implants, then that will impact us in terms of the artifacts when we do our CT simulation. So the example of what a big prostate look like. So one of my patients are like that. So with a big median lobe. So definitely, if you were to treat these patients with any sort of radiation, even without SPRT, patient is likely to go to obstruction. So this probably best to send them to the urologist for a TURP before we do radiation. So we recently published our data from the NCCS on the efficacy, toxicity, and quality of life outcomes of SPRT in prostate cancer patients. And basically, we looked at about 105 men that were studied, and essentially, toxicities are very low. There were actually no late more than grade 3 or above GU or GI toxicities. And majority of the acute toxicities are grade 2, and they occur only 2 weeks post-treatment, and that's only in about a quarter of the patients, so between 23-24%. And late toxicities are actually very low. So grade 2 and higher toxicities for both GU and GI are actually in the range of less than 5% in both cohorts. I'll talk a little bit about the cohorts that we have. And again, when we look at the EPIC scores, there were actually not much changes for these patients at a median follow-up of about almost 5 years. So again, cohort A and B. Cohort A is when we started, where we actually looked at mainly patients that are low to intermediate risk. And in these patients, we actually treated them with a standard dose of 36.25 in 5 fractions. And once we have completed accrual into this cohort, we are more comfortable. We expanded our indications to allow for also unfavorable intermediate risk. And in this group of patients, we allowed for higher dose of 37.5 in 5 fractions to the prostate, and also 35 gray in 5 fractions to the seminal viscous where indicated. And of course, the follow-up group time for the cohort B is much shorter. But essentially, this shows the description between the 2 groups, and most of them are, lower stage, between CT1 to CT. I think T3 was mainly in the cohort B, and most of them are actually Gleason 7, although there were some with Gleason 8. And core burden usually less than 50% for the first cohort, and we allowed for more sort of extensive disease in the second cohort, essentially. And for cohort A, actually, there was mandated to have no use of androgen deprivation, whereas for cohort B, some patients had short-term hormonal deprivation being given. So look at the adverse events. Basically, you can say that, looking at grade 3, there was only 1 event where a patient was obstructed and requiring a catheter. But generally, most of them were actually grade 1 and 2. And, as time goes on, they all fade, and majority were actually back to grade 0 toxicities. Looking at IBSS score, again, there was not much change. There was a bit of acute effect due to swelling of the prostate. But, at the end, beyond 3 months and further, it all stabilized down back to baseline. And so between cohort A and B, actually not much difference between the 2. Same goes for the EPIC scores, which is a measure of quality of life. Again, looking at urinary as well as bowel or sexual, there's not much difference between patients as they progress. So it's well maintained in this cohort of patients. PSA decline. So without the use of hormones, actually, there was a sharp decline of PSA. And if we can look at a decline of more than 50%, seems to indicate that if we give a higher dose of 37.5, the decline is much quicker. But eventually, at the end of about maybe beyond 1 year, it's much the same between the 2 groups. So a lot of them do achieve good decreases in their PSA, indicating control of the disease itself. PSA control, as shown this, and biochemical relapse survival actually essentially is 94% for this group of patients. So next, we move on to what's new in SBRT. So a little bit about spacer, fiducials, use of transperineal ultrasound, which is what we have here, dominant intraprostatic lesion definition, and also something to reduce the artifacts of metal implants by use of IMER, if that's available on your CT simulator. So what is a spacer? A spacer is something that you can inject between the prostate as well as the rectum. In our center, we use the spacer or our hydrogel system, and that's inserted together with the urologist, usually about 1 to 2 weeks before we do the CT simulation, and then prior to SBRT treatment itself. So what you can see here in white is where the spacer is going to be. So it's placed actually between the prostate, the SV, as well as the rectum, and creates a space of about 1 centimeter. So that actually allows us to drastically decrease the dose to the anterior rectal wall. In axial representation of the same thing. And so this is what it will look like. So if we contour out where the spacer is, for patient number 1, we can actually have good distribution of the spacer itself all the way down to the apex, which is sometimes a bit challenging. For patient number 2, a bit short on the apex, but overall, there's still good sparing by pushing the rectum posteriorly. And so these are the representative slice actually of where the spacer sits. It should be as symmetrical as possible, but sometimes it's difficult to achieve that. But overall, you can see the benefit of having something to push away the rectum, and that will allow us to achieve even lower rectal toxicities as reported in our paper. So possibly at health patients now, less than 5% chance of grade 2 rectal toxicities after treatment. The use of transperineal ultrasound is what we have here. It's called the Clarity system, where we can actually image the prostate during treatment and track prostate again to monitor for intrafractional motion. And it allows us also to identify where the prostate and also where the spacer is. So we're now trying to explore the use of using ultrasound also to define the spacer. Otherwise, patients would definitely need to have an MRI to define it because it's not well seen on the CT. So this tool actually basically to look at the trigger imaging video. So what happened here is that as the patient is treated, orthogonal X-rays are being taken, and you can identify where these fiducial markers are. So it's a bit like those in your camera. So if it's within the circle, it will be green, and if it's orange, means it's slightly out, which means that patients may have shifted, and you may want to stop beam and reset our patient if you find that that is important. So the other video shows much the same thing. Okay. So dominant intraprostatic lesion is what we have started to do with the what's been published by the FLAME trial recently. So you can identify where the dominant prostatic tumor is in the prostate itself by looking at ADC maps. And using the MRI, we are able to contour it and possibly ask the planner to put a hotspot within the tumor differentially using the use of simultaneous integrated boosting. So hopefully that will allow us to have better control in where there are higher density of tumors. You can define DLL or dominant intraprostatic lesion for higher periods, right? And therefore, by giving a higher dose, hopefully the control will be higher, but that needs to be proven. But looking at the results from FLAME, I think it's certainly something that is very promising. So I come to the end of the talk, and I'd like to acknowledge my co-workers that helped me in the presentation of the slides, and looking forward to the questions and answers later on. Thank you very much.
Thanks, Dr. Tuan, for your insights and sharing of your experiences and some of the pitfalls for SBRT for early stage prostate cancer. So we'll take the questions at the end. Feel free to type in any questions in the Q&A section. We'll move on to our next speaker. Our next speaker will be Dr. Melvin Chua. Dr. Melvin Chua is a senior consultant radiation oncologist and head of department of the thoracic and head and neck cancer, National Cancer Center, Singapore. He is a clinician scientist and principal investigator of the Tan Chin Tuan Laboratory of Optical Imaging Photodynamic and Proton Beam Therapy Precision Radiation Oncology Program. His research is focused on the discovery and translational cancer genomics and the development of biomarker-directed clinical trials in nasopharyngeal cancer and prostate cancer. Today, Dr. Chua will speak on the use of novel agents in prostate cancer. Dr. Chua, please.
Thank you, Dr. Tay. Before I begin, thank you to the FARO Organizing Committee for inviting me to sort of speak to you all at this webinar today. And the topic I'll be covering focuses on the use of novel agents with prostate radiotherapy. These are my disclosures, nothing relevant to the talk today. And this will be the broad scope of my talk, covering the following outline. I thought it's good to just sort of explain a little bit on the rationale on how we actually combine systemic therapy. And the mainstay here would really be ADT in the treatment of high-risk disease. Then following which, I'll also elaborate about the mechanisms that underpin the current thinking about a synergy between ADT and radiotherapy, specifically to DNA repair, as well as other pathways. Then we'll switch gears to sort of share and discuss about some of the evidence with regards to the use of ARIs and the evidence in support of how ARI may be able to induce a much deeper tumor as well as biochemical response in the neoadjuvant setting. And a lot of these trials were actually done in the setting of radical prostatectomy. Then it is important to, of course, discuss about the recent STAMPEDE data and share some of the ongoing trials and how this data may actually be complementary to the ongoing trials. And then finally, to end my talk, a little bit on the biomarker space. So briefly, I think these are the broad principles underpinning why we combine radiotherapy with a systemic agent. I think we all recognize that really, as I consent most of my patients, whether they go through radiotherapy or surgery, I mean, these are merely tools of local treatment for local control. And of course, local control is important. But at the same time, we know that these advanced tumors have a high propensity for nodal and distal metastasis. And I think the more recent studies on next generation imaging pretty much confirms that is the case. Now, in addition, with radiation especially, given that DNA repair is such an integral mechanism underpinning radiation-induced tumor cell killing, there's another dimension for interplay between ADT and radiotherapy here in the form of synergy. Now, of course, large randomized trials, and I'll show you briefly just to recap some of this data, have shown the benefits of local treatment, either in the setting of backbone of ADT or when combined with ADT against radiotherapy alone. Now, of course, there are still questions of optimal duration, but ultimately, I think as we pivot into why is there a need for novel agents, I think the question here really is, do we think ADT itself, whereby be it surgical or medical castration, is tumoricidal? Quickly, this is the PR3 data. So briefly, this trial compares between a lifelong ADT versus ADT plus radiation, and the schema is shown here. Now, this is the survival curves at 7 years, and it's pretty impressive. Just to point out here that for patients treated with combination treatment, essentially you have 90% of patients who remain alive at 7 years. And this is the updated analysis, again, confirming the hazard ratio and the extension of benefit even with longer term follow-up. Now, on the flip side, when you talk about combining ADT in the backbone of radiation, it is also impressive to see that while in the earlier study with an ADT backbone, we achieve a hazard ratio of 0.7, here it is clear that the combination of ADT to just a local treatment is far more effective in terms of disease control. And this translates to an overall survival benefit with a hazard ratio of 0.5. And the schema of the radiation is shown here. And we can all agree that this is largely in accordance with contemporary standards. Briefly, this is the TROP 9601 trial. This is a fairly old trial, but the reason for bringing up this trial here is that they actually tested different duration of hormonal therapy given at the neoadjuvant and concurrent setting. The cohort comprised primarily of high-risk disease. And it is interesting to note that, of course, at a short course of treatment, of exposure of 3 to 6 months, there seemed to be a benefit over just treatment with radiotherapy alone. Of course, I won't imagine that with the contemporary data, that addition of longer duration of ADT would have increased the PSA control, certainly. But nonetheless, suggests that provides overwhelming evidence that even a short course of hormonal therapy, be it either for tumor control or radiation sensitization, proves a benefit over radiation alone. Now, this is the meta-analysis, which comprises of a most recent evidence assimilated from 12 different trials here. And this is the work led by Amar Kishan from UCLA with the MARCAP Consortium, and they essentially analyzed 10,000 patients. But briefly, what I wanted to showcase in this talk is that ADT confers a benefit, and here they ascertain benefit by a surrogate endpoint of metastasis-free survival. And we know that metastasis-free survival is a robust surrogate for overall survival of prostate cancer-specific mortality for localized prostate cancer. Now, what is interesting in this analysis is that when they divided or stratified by whether the patients received or they asked the neoadjuvant question versus the adjuvant question, I think this is an extension of the earlier study published in JCO last year, but hints to us that the neoadjuvant prolongation may be targeted at radiation sensitization and less so for targeting occult metastasis, while the adjuvant therapy prolongation would actually make a difference in terms of enhancing distant control. So I think it again hints to us that there are two mechanisms at play that actually synergizes with radiotherapy. As we think about novel and future schemas, it is important to then think about how do we, what pathway do we want to target in terms of how we sequence these therapies. So briefly, as I mentioned, I think this is a schema of how ADT or medical castration, be it either by the deprivation of testosterone or targeting the AR receptor, actually might interplay with radiation. Now, what is clear is that radiation does induce double-strand breaks, and through good evidence by the group by Charles Sawyer et al., showing that, in fact, when you target the AR receptor, it actually leads to a transcriptional downregulation where you basically get a suppression of all the genes related to repair of end joining. And by that mechanism alone, that then basically acts as a radiation sensitization effect. And to compound this benefit, we know that after radiation exposure, there's in fact an AR receptor expression, overexpression. And so therefore, if you think about this feedback loop, inhibiting the AR receptor would thus then further suppress the DNA repair pathway and then potentially further enhance the effects of radiation. And this is proven in vivo. So this is work led by Professor Thomas Halliday from Stockholm. And this is the schema of the trial. So briefly, they had patients treated with neoadjuvant radiotherapy before going on full dose of radiation. Patients then underwent a biopsy after a leading period of radiation, and then when they had prior exposure to medical castration. And just to show here that this is H2AX staining in the biopsy tissue. So these are actually taken from the in vivo biopsies taken from patients. And just to bring you through this plot quickly, that if you're treated with radiotherapy alone, then the numbers here representing the residual DNA damage is actually much lower with patients treated with radiation as opposed to if they had received prior medical castration before. And this is alluded to the suppression of DNA PKCS, which is a critical pathway or protein implicated in end joining. So with this, it nicely pivots, allows me to pivot to the novel trials or novel agents. And just to quickly bring you through a whole slew of studies. So this is the JETUC trial study. And the reason why I brought this up was that while it did not use any of the novel agents, it still looked at the combination of chemotherapy, this is a old school chemotherapy, and 80% of the patients on that trial underwent radiation. Now, what is clear is that the addition of chemotherapy, although it is not as impressive as we hoped, that did confer a relapse-free survival, although the updated analysis did not show an OS benefit. So the rationale behind combining novel ARIs is that, perhaps alluding to the point I was making earlier, the ADT alone may not be tumoricidal. And there is also evidence showing that profound castration, and by that it means a very low level of testosterone, could actually lend itself to a deeper biochemical and pathological response, potentially conferring a benefit for survival. And so the initial studies looking at combination of ARIs in localized disease were largely done in radical prostatectomy series for the purpose of actually getting tissue. So let's explore some of the signals of this trial. So this is one of the early trials comparing between, it was a two-arm, single-arm study looking at enzalutamide alone versus enzalutamide plus ADT, so LHRH agonist. And the endpoint here was PAF complete response. Now, of course, if you look at that index alone, it is by far hardly impressive if you look at just patients treated with enzalutamide alone and in combination, where almost none of the patients manifested a complete response. But if you just look at the minimal residual disease, it would seem that there's a hint of a response if you combine between enza and ADT as opposed to single agent. Now, is there evidence in terms of combination of radiotherapy? So this is again a very nice single-arm study done by the Dana-Farber group led by Paul Nguyen. And here they essentially just look at monotherapy enzalutamide given neoadjuvant and concurrently, short course with radiation alone. And the endpoint was PSA suppression. So if you look at the results here, it is clearly impressive that at a pre-specified endpoint, that a large majority of patients, in fact, 75% were able to achieve a complete PSA suppression. And by that, it was defined as 0.2 because that was the same benchmark one would use if patients underwent surgery. Now, what about another agent? Here they looked at abiraterone. This is work led by Lenny F. Stachio. And this was a bit of a different study where it was primarily targeted at looking at biomarker analysis for response and resistance. So patients received either ADT alone or AAP plus ADT. It was a randomized phase 2 trial. And if you just look at biochemical response, it's not surprising that if they had combination abiraterone, then a much higher proportion of patients were able to achieve nadir. And the majority of these patients went on to receive radical prostatectomy. Now, this is the tumor bulk at the time of surgery. So again, very impressive findings showing that abiraterone, when combined with ADT, does lend itself to a much deeper biochemical and PAF response. Now, what is, however, interesting, if I were to show you here that upon treatment with combination treatment upfront, that the investigators found that while we did see a PSA and a PAF response, that in fact invoked a potential resistant mechanism in a sense that these patients manifested a compensatory growth receptor overexpression. And if you look at some of the paper with regards to deciphering the mechanism to enzalutamide, it suggests that the growth receptor compensatory overexpression does seem to play a part in terms of mediating enzalutamide resistance. So if you then look at this plot itself, that if you have a much higher proportion of GR expression, then these patients tend to have a higher volume of residual disease compared to those who do not manifest this overexpression. So it's interesting to see that while it may be fine and dandy in terms of clinical response, that we hope that potentially in some patients, early treatment of this dual agents, this novel agents, might in fact trigger a cascade of a resistant mechanism that we should be aware of. Briefly, with regards to how about apalutamide, so here we also ran a trial at the NCCS led by Dr. Lee Rei-Xiong and myself was in charge of the exploratory analysis. So this is a trial schema of which we were able to obtain biopsies pre, post neoadjuvant apalutamide and at the point of surgery. And this was the response. And quickly, just looking at PSA response alone, it was interesting to us that in a cohort of 25 patients, Well, we expect that apalutamide, being a third-generation AR receptor inhibitor, would naturally itself induce a much deeper PSA response. That this was not the case in our cohort of 25 patients. While we acknowledge that some patients had a very deep sort of PSA response, there were some patients for which apalutamide seemed to be not really inducing a deep PSA response as we would hope. And the endpoint of this study was PSA nadir at six months post-surgery. Now, in terms of PEF grading, just to briefly bring you through, so we also looked at PEF response by a novel grading system, A, B, C, whereby C would be a minimal response and A would be a profound response. It would seem that this was independent of Gleason grade, but certainly in this trial, we saw a very promising control, even for a predominant high-risk disease subset treated with just single agent apalutamide with surgery. Now, the exploratory analysis was interesting. So here, just looking at the biochemical response, so the maroon color would be the non-responders and the blue would be the responders. And if you just look at AR activity, where a dark red means that the AR activity is high, while pale color suggests that the AR activity is low, what we saw was that in a subset of patients with a very low AR expression, albeit baseline activity, this are more likely to be non-responders as opposed to patients with a baseline normal or higher AR activity. And in fact, it was interesting. This was the pre and post biopsies, where we found that while the responders would have a high AR activity pre-treatment, and then upon inhibition of apalutamide, as we expect, have a down regulation of AR activity. But for the non-responders, in fact, there seemed to be a upregulation of the AR pathway, and along with it, an enrichment of a MEEK oncogene expression, which we know harbors for an aggressive phenotype. So like the earlier study, I think it's important to note that early treatment may thus invoke some resistant mechanism of aggressive disease, which we need to be cognizant of. Now, finally, in terms of doublet combination, what about novel treatment with enzalutamide and abiraterone? Here, this is a randomized phase 2 trial showing patients comparing between those who receive enzalutamide plus abiraterone versus enzalutamide alone. And if you just look at the PSA control, while it may not be distinctly different between the two arms, what is interesting that if you then look at a different sort of endpoint, be it PEF response or any PEF response, it would seem that combining more agents does induce a much deeper PEF response. But what it tells me about this study is that we should be modest about our expectation if we were to just treat with novel agents alone, with just one single agent alone, because while we may see a PSA response, I think the actual tumor response itself may not be as profound as we would like. This is another trial that was led by Sean McBride, presented at ASCO last year, where he looked at abiraterone and apalutamide, basically very deep hormonal castration with just SBRT alone. And this was the trial schema. And the other thing to highlight here is that the hormonal therapy treatment was short course. This was the patient characteristics, but the key result here I want to showcase was that in a very predominantly high-risk cohort, now the yellow colors will represent patients who progress, I believe, but it would seem that these are actually very impressive results obtained by just a very short, intense course of multiple lines of novel combination therapy with radiation just to the prostate alone, thereby suggesting again that novel agents may have a part to play, but we really need to think about how do we sequence them to achieve the optimal efficacy. And then finally, I think it gives me time to speak about Stampede trial. And we are all aware of the data, but I think just to jump to the data that I thought was most impressive here was that what this study shows us is in the M0 patients with advanced disease, be it N0 or N positive, that the addition of abiraterone on top of ADT plus radiation would actually yield an impressive 10 to 20% metastasis-free advantage, even at the early time point. If you look at the 2-year, 3-year mark, you're already being able to see a signal for efficacy. But the thing here is that when you look at, because the trial was designed partly to address whether the single novel agent versus the dual novel agent, whether that itself would yield a difference in efficacy. But this plot here, this exploratory analysis hints to us that does not appear to be the case, yielding similar hazard ratio for both subsets of patients. And this is the overall survival advantage. And also for the secondary endpoints, again, the results are consistent for an efficacy. So what about some of the ongoing trials? There's the ENZARET trial, which looks at combination of enzalutamide in use in the same setting with an ADT with RT. So this trial was last presented at ASCO GU 3 years ago, and we would expect the trial to read out hopefully in the next two years. This is another trial that was just presented at the most recent ASCO GU, looking at darolutamide, another ARI inhibitor. So I think over time, with all these phase 3 trials maturing, we should have a good idea or understanding of the, where these agents play a part in this advanced disease space and how the implications might be in terms of subsequent treatment when these patients relapse. So I think to summarize, I hope that I've shown that ADT plus RT itself is a precision-targeted combined modality. I think the synergy is multifaceted. There are two angles here based on the data I've shown, that there's a component of radiation sensitization, but in terms of the novel agents, perhaps apart from just targeting the local disease, there might be a play in terms of targeting occult metastasis. And this is important, especially in the current era. We tend to do a lot of next generation imaging for our patients. I think there's enhanced efficacy with novel agents, as I've shown, and really begs the question, is double blockade better given the early studies showing the potential for evoking a resistant mechanisms in some patients? I think in interest of time, I won't go into the biomarker studies, but I'm happy to take any questions at the Q&A, and thank you for your attention. Again, thank you for having me here.
Okay, thank you, Dr. Chua, for the very comprehensive talk indeed. Our next speaker will be Dr. Wee Kiat Huat. Dr. Wee is a consultant in the Department of Radiation Oncology at the National University Cancer Institute. His clinical interests are in breast, urological, and sarcomas. Today, Dr. Wee will speak on brachytherapy for prostate cancer. Dr. Wee, please.
Thanks, Jeremy, for that kind introduction, and thank you very much to the organizers for inviting me. Share my screen. All right. So today, the topic of my talk is about brachytherapy for prostate cancer. So we're moving from the cutting edge to something that is very well established and has been in use for a very long time. So the brief scope of my talk, I'll briefly go through what brachytherapy is, the relative advantages of brachytherapy, the different types of brachytherapy for prostate cancer, and then I'll talk a little bit about how it's done and the indications for its use. Then, if time permits, just a short sharing of our clinical experience. So I'm sure this is nothing new to all of us. Brachytherapy basically is a form of radiation therapy that seeks to exploit materials that emit radiation, which are then placed directly into or near a tumor. And actually, brachytherapy has been in use very soon since the very early since the discovery of X-rays. And the first documented use of brachytherapy for prostate cancer was actually in 1914, where radium source was actually introduced by a urethral catheter to target the prostate. So again, as I'm sure we're all aware, there are multiple cancer subsites in which brachytherapy can be employed. And the advantages of brachytherapy are that a high dose can be delivered in a relatively short time. Obviously, with a shorter treatment time, there are advantages. And certainly, in particular cancers that have a low alpha-beta ratio, there are further advantages with this. Additionally, the sharp dose fall-off allows us to give lower dose to the surrounding organs, and thereby leading to lower toxicity and or allowing a higher dose to the target. So this slide shows the radiation treatment plans for in A, IMRT, in B, VMAT, C, SBRT, and D, brachytherapy in the treatment of prostate cancer. At one glance, we can see that there's an obvious advantage brachytherapy over IMRT and VMAT, where you can see that the color wash showing the dose levels are very much more conformal in brachytherapy. But even when compared against SBRT, we can see that the blue color wash, which represents the 25% isodose, is very much more conformal in brachytherapy. Of course, there are special considerations when we are thinking of employing brachytherapy for the treatment of prostate cancer. There's always a risk of radiation exposure, and there's a potential for complications due to the invasive nature of the process. And hence, there's a need for specialized training in regards to the insertion of the catheters and applicators, as well as the radiation planning portion of it. Brachytherapy for prostate cancer can be subdivided into low dose rate of up to 2 gray per hour or high dose rate greater than 12 gray per hour. The advantages of high dose rate brachytherapy are that there are less radiation safety concerns, as the patient is not radioactive in between or after treatments. There's also less risk of radiation exposure to staff and the public. There's more clinical control over the dose administration, as we are able to select from multiple dwell positions and vary the dwell times. And as I've mentioned earlier, there's potential advantages in the treatment of cancers with a low alpha beta ratio. For low dose rate brachytherapy, radioactive seeds of iodine, palladium, or cesium are multiple seeds numbering from 60 to up to 120 are placed in the prostate using transspectral ultrasound guidance. You can see from the diagram on the left, multiple seeds are spaced out within the prostate, and on the right we can see the X-ray demonstrating the many seeds that have been implanted. In contrast, high dose rate brachytherapy involves the implantation of temporary catheters. So you can see in the picture on the left, as well as on the diagram on the right, multiple catheters are again implanted using truss guidance. And this allows us to use iridium-192 source, which is actually introduced via a remote afterloader. In our center, we favor a two-step planning technique for our HDR brachytherapy plans, whereby truss guidance is used for the catheter implantation, followed by a CT for voluming and planning. Very briefly, the CTV then is the prostate capsule rather, and any extra prostatic disease that the patient is known to have. There's also a consideration of the addition of a 3 to 5 millimeter expansion to a PTV. This next slide shows the radiation treatment plan for high-dose brachytherapy. You can see the multiple catheters that have been implanted, and by means of utilizing multiple dwell positions and varying the dwell times, we're able to come up with a highly conformal plan which covers the PTV adequately, and at the same time sparing the relevant organs at risk, which mainly are the urethra as well as the rectum. In terms of indications for use of, the ways in which brachytherapy can be employed, the main ways are either as monotherapy or as a boost after external beam radiotherapy. For brachytherapy as monotherapy, mainly is limited to low and very low intermediate risk prostate cancers, whereas for boost after external beam RT, we utilize it in intermediate or high risk disease. Multiple single institution series and retrospective reviews have demonstrated that brachytherapy monotherapy has equivalent biochemical control and lower rates of toxicity, in particular GI toxicities, as compared to those escalated external beam therapy. And in fact, the American Brachytherapy Society guidelines in 2012 made a recommendation for HDR monotherapy to be fractionated for low to intermediate risk disease. And by employing it in this way, demonstrates a good 5-year biochemical control of 85 to 97%, low grade 3 and above genitourinary toxicities of 1 to 3%, and minimal gastrointestinal toxicities. ESCO guidelines in 2017 again mentioned that LDR monotherapy is an option, low and low intermediate risk disease, but did not make any specific recommendation for or against high dose rate brachytherapy as monotherapy. And in the latest JAC Astro guidelines just released this year, again, they mentioned that there's no evidence-based recommendation that can be made for HDR monotherapy at present, but it may be used for low to intermediate risk prostate cancer. And there was a specific mention that in the presence of extensive prostatic calcifications, HDR is preferred due to the favorable dosimetry as compared with low dose rate brachytherapy. In this sphere, randomized data is few and precious. So this small phase 2 randomized pilot study compared high dose rate and low dose rate brachytherapy as monotherapy in localized prostate cancer, whereby a single fraction of high dose rate brachytherapy was compared against the implantation of iodine-125 seeds. And in this study, the primary endpoint was to assess the difference in health-related quality of life, in particular in the urinary domain. At 1, 3, 6, and 12 months, the IPSS and EPIC urinary irritative scores were significantly better than the HDR arm. And there were no significant differences in the incontinence, sexual function, or bowel habit scores between the two groups at all the measured time. Furthermore, time to IPSS resolution was shorter in the HDR group compared to the LDR group. And as for physician-reported grade 2 and above toxicities, there were no significant differences in urinary, bowel, and sexual toxicities. No grade 3 toxicities were reported. Large retrospective series also suggest a reduced acute GU toxicity for HDR brachytherapy as for monotherapy, and equivalent GI and GU toxicities compared against LDR. So now we move on to the utilization of brachytherapy as a boost following external beam RT, the whole pelvis. And the largest randomized trial investigating this was the ASCEND RT trial, which randomized about 400 patients into either dose escalated external beam RT to 78 Gray, and compared this against another group which had a low dose rate brachytherapy boost following 46 Gray to the whole pelvis. What the trial showed was that there was actually a statistically significant biochemical progression-free survival benefit for the low dose rate boost arm compared to the external beam arm. And this benefit was about 20% at 9 years. Biochemical progression-free survival benefit persisted when the patients were analyzed according to risk group. So here we see the intermediate risk group showing again that there's a 24% biochemical PFS benefit at 9 years. And in the high risk group, 20% biochemical PFS benefit at 9 years. At a median follow-up of 6.5 years, the grade 3 and above GU cumulative incidence was 18% versus 5%. This was statistically significant, with about half of them being urethral strictures. The grade 3 GU toxicity prevalence at 5 years was 8.6 versus 2.2%. and there was no overall survival benefit for brachytherapy. The authors then concluded that brachytherapy boost should be considered in healthy younger men with unfavorable, intermediate, or high-risk disease. In the 2020 update, with a median follow-up of about 10 years, the biochemical progression-free survival benefit persisted at 10 and 15 years. And however, there was still no overall survival or cancer-specific survival benefit. This study was not powered for that though. So again, the authors maintained their conclusion that brachytherapy boost should be considered in healthy younger men with intermediate to high-risk disease. Two other randomized trials have also showed biochemical relapse-free but not overall survival benefit. And unsurprisingly, a meta-analysis which included all three of these trials showed a 5-year biochemical PFS survival benefit in favor of brachytherapy versus external beam RT boost with a hazard ratio of about 0.49 and no difference in overall survival. So going back to the guidelines, the 2017 ESCO guidelines does make a mention that patients with intermediate or high-risk prostate cancer receiving external beam RT should be offered brachytherapy boost if the patients are deemed eligible. A large National Cancer Database review in 2019 also suggested that there may be a survival benefit with brachytherapy boost as compared against external beam boost. The usual caveats do apply as this is still at heart a retrospective review. And in the latest ISRO guidelines, similarly mentioned that a brachytherapy boost should be considered in those being planned for radiotherapy treatment in patients with intermediate or high-risk disease. Looking ahead, some of the other ways in which brachytherapy is being considered are through in the use as focal brachytherapy, focal boost brachytherapy, and salvage brachytherapy. So I'll just talk very briefly about each in turn. Focal brachytherapy is essentially the treatment of partial part of the prostate rather than the whole. So the purported benefits are a reduction in toxicities, but this is largely considered still investigational. Focal boost brachytherapy is very much similar, but the idea then is to still treat the entire prostate, but to give an extra dose to any obvious dominant lesions that can be seen. This is very much akin to what I think Dr. Jeffrey Tuan mentioned earlier. Of course, this still remains investigational as well. And lastly, salvage brachytherapy is the use of brachytherapy to treat locally recurrent prostate cancer in those who have already received external beam radiotherapy in the past. So while some centers have moved on to do this, it's still not considered standard, and more studies are required before its widespread adoption. So very briefly, I just like to run through some local data that we have for patients that we treated with brachytherapy. So in our center, we reported on our treatment of 75 patients with high-dose brachytherapy boost after the 45 day to the whole pelvis. So you can see the evolution of the dose fractionation, whereby we had initially treated patients with 2 fractions of treatment, but subsequently moved on to a single fraction boost. And with a median follow-up of about 5 years, we found that about 15% of patients developed biochemical failure, 6 of whom had distant metastasis. All the patients who developed biochemical failure had high-risk disease. And this gave us an overall 5-year biochemical control of about 85%, which when split into risk categories was about 80% for high risk and 100%. So this Kaplan-Meier estimate just shows the difference between intermediate risk group, which is about 100%, versus the high risk group, which is about 80%. median time to PSA failure was 3 years, and the 5-year cancer-specific and overall survival was 97% and 92% respectively. Toxicity-wise, we can see that toxicities overall were very low, with very few incidences of late GU toxicities, and low incidences of both acute and late GI and GU toxicities, grade 2 and below. I think this brings me to the end of my presentation. Thank you very much for your attention.
Thanks for that comprehensive talk, Dr. Ooi. We have a question for Dr. Melvin Chua regarding the biomarkers. Which biomarker looks the most promising as a predictor of response?
Yeah, so this is a great question actually, and my apologies, I was not able to go into the part of the talk. So there's a FDA-approved molecular assay called a Decipher. So Decipher essentially is a 22-gene assay that's based on the RNA expression, and it's actually, you don't need fresh tissue for it. It can be done off archival tissue, and it's been widely validated in both radiotherapy treated series or post-surgical series. Now, the test itself, apart from just providing a risk score, so the first layer of information that you get is essentially the risk of the patient, defined by the score itself, ranges from 0 to 1, and any patient with a 0.6 score and above will be considered as high risk, and this is high risk for distant metastasis. Now, in addition to that, you also get information with regards to the AR activity, and also whether the tumor favors more of a basal or luminal status. So this basal luminal status, for some of us who treat breast cancer, will be familiar. Essentially, what the investigators did before was they took the same breast cancer signature and applied in prostate cancer, and they found that it actually also teased it apart, which is not surprising given that both are hormonally driven cancers. But what is interesting is there are 2 papers. I'll refer you to them. Most recently, it was published by Felix Feng in 2021 in JAMA Oncology, where they showed that from apalutamide or ADT. So the ADT analysis was was published, was based on a retrospective cohort, and the apalutamide analysis was based off the Spartan study, which was essentially in non-metastatic castration-resistant prostate cancer. So I hope this answers the question. I think I know for a fact that the company has actually gotten their hands on the STAMPEDE samples, and they are doing an analysis on the STAMPEDE data that was just published last year, presented in ESMO, and hopefully we may see some data in Astro this year.
Thanks, Dr. Chua. So we have a question for Dr. Tuan regarding 35 gray as SBRT as effective as 36.25 with less toxicity. Is there any advantage to dose escalation to 40 gray?
Yeah, I was trying to type in at the same time. But anyway, I think that our experience has been that the results using 36.25 actually has been very good. So even moving from 36.25 to 37.5, the benefit as we see has been a quicker response to PSA. Overall, response beyond 1 year is still relatively good. So to answer the question directly, we are comfortable with keeping the dose to 37.5 as a max. Beyond that, to 40 grays will probably lead to higher toxicities to the urethra, even if we can do spacer to avoid the rectum. So one of the intermediate kind of strategies perhaps is to do a DIL boosting. So which means that you just focally increase or dose escalate to the tumor rather than the entire gland. So our practice is not to chase to 40 gray. Reports that others have used have reported slightly higher toxicity. Unless you have a CyberKnife or you have an MR Linac, then I think perhaps you can try that. But using conventional VMAT, I think if you want to start, then I think start with a lower dose. 36 to 37.5 is definitely fine.
Thanks, Dr. Tuan. Any other questions from anyone?
Actually, I'll could have actually have a question for Kiat Huan. I mean, the Ascend RT, and perhaps to you too, right, Jeremy? I mean, you all have a very strong sort of Breckie program. The Ascend RT does provide good evidence for HDR boost. I mean, well, LDR boost, but and then of course, you know, we have seen a series from Amar Kishan as well, showing that potentially brachytherapy boost may have a advantage on distal metastasis control. So just I wonder your thoughts on what do you think in terms of, you know, the Breckie itself? Do you think it actually confers just a dose benefit, or there's other pathways at play? And number two, so in your practice, how do you select? I mean, do you have a program about all your high-risk patients will go on to this brachytherapy boost program, or maybe share your sort of experience?
Hi, Melvin. Yeah, thanks for your question. Maybe I'll touch on the second part first. I think in general for patients who are unfavorable, intermediate, and high-risk disease, I generally make it a point to have a discussion with my patients about the utilization of brachytherapy boost. Of course, you know, patient selection is key as well, and tend to favor and push it a bit more in the younger, in whom I would expect it to translate into a tangible benefit. Yeah, and I guess in your first part of your first question as to how the mechanism of the benefit, well, I must admit I'm not too sure, but I would speculate that, you know, the higher dose, the properties of brachytherapy probably allows us to escalate the dose to a much higher level, and my guess is that's where the benefit is derived from. Jeremy, any insights in this sphere?
Yeah, so I think series have shown on pathological specimens and biopsies that have shown that the higher radiation dose you give, the larger proportion of patients will have negative biopsies. So that's where I guess the benefit is. Local control and then biochemical progression-free control. Yeah.
Actually, as a follow-on, can I just ask Jeffrey, maybe, is there, are you guys looking at SBRT as a boost at all?
Yeah, I think that's certainly something to consider. As you know, for prostate, there are so many ways of treating the patients. So one of the possibilities is that you could actually do a standard pelvic fill to about 45 to 50, and then transition what you normally give for HDR boost and give it via SBRT. Certainly is possible. We haven't thought about it because there's just so many ways. You can understand in your consultation with the clinic, going through the options for surgery and radiotherapy already takes 1 hour. Going through the various options for RT is going to take another more. So it's certainly something possible. But what I think is useful for us is that I've actually thought about using SBRT boost to the lymph node as a possibility. So if you have multiple lymph nodes and you want to cut short the time to have a greater BED by higher dose per fraction, then perhaps there's something to explore. And I think to follow to Melvin's topic is that I think I was just wondering whether it could be a function of dose per fraction, because you're giving such a high dose for either HDR or low dose, like lower dose, you know, the sensitivity is much different from our conventional dosing. All this is going to change as you move towards moderate hypofractionation as well as extreme hypofractionation. So, you know, the comparator arm or the standard of care is ever going to change. So I'm not sure, but I believe the topic is any sort of dose intensification, either locally or systemically, is going to lead to improved outcome. How you want to deliver it is how you're comfortable with. And brachytherapy may be the most conformal way, assuming that you can deliver it in a particular place. So as Jeremy we had a private conversation of, you know, if it's in the SV, it's very hard to treat unless you can implant your catheters there. So these are the limitations. But if you can see it, you can put it right in the DLL, you definitely can give higher dose because your dose can reach 200%, right, in your catheters. Yeah.
Thanks, Dr. Tuan and Dr. Wee. So we have a question for Dr. Chua. In prostate cancer, similar to breast cancer, is there an entity like triple negative or ER negative where ADT may not have such a big benefit?
Yeah, it's a great question. So the answer is yes, there is. So the likewise to, you know, breast cancer, they have the basal luminal A, luminal B. So again, there's a dominant sort of basal phenotype. And again, if you look at the two papers I mentioned, the basal tumors, as you would expect, didn't seem to benefit so much from the addition of ADT or apalutamide. Now, again, I think it's not that they don't respond entirely. It's just that it may not be as profound as we would like. So perhaps for these patients, they may need another agent like a PARP inhibitor or something else, as opposed to the just targeting the AR pathway. And again, just to add, I think in our analysis of the NEAR trial that I spoke about, although AR activity was the predominant predictor of response by PSA, again, we saw that the basal luminal status also associated itself with the likelihood of a PSA response. So the basal tumors were less likely to get a deeper PSA response and correspondingly a PEV response.
Thanks, Melvin. While we are on novel agents, I have a question for you, Melvin. Just now you did mention that novel agent, in addition to ADT, induces increased PEV-CR and biochemical response, but we also know that this is a function of the duration of the treatment, right? So what, in your opinion, is the optimal duration of double agent treatment before definitive radiation or surgery?
That was a great question. And I think previously I wouldn't have been able to answer you, but if you look at the Amar Kishan's meta-analysis, right? And I think, that analysis was predated by another analysis that was published by Dan Spread. I can't remember which RTOG trial they addressed or they looked at, but what they showed was that if you are just targeting it seems, radiation sensitization effect, or targeting occult metastasis, it seems that the lead-in time for your hormonal therapy may not actually play a big part, right? So whereas the adjuvant therapy would seem to have a more profound effect, and it's not surprising because if you then look at most of our SBRT patients or RT alone patients, the time to nadir is protracted, right? So it's not just a typical RT killing mechanism. I think it might be an immune response that's cascaded. Now, that being said, I think practically speaking, we do wait a bit of time, simply because a lot of these advanced cancers, they come in bulky, right? And we do know that, after a period of 3 months or longer, especially with, if you're looking just ADT alone, it may take a bit of longer time, but if you combine with abiraterone, as we have had some experience, then about 3 to 4 months, you do get a substantial shrinkage, and it makes it a lot easier to treat because otherwise they get quite a fair bit of toxicity.
Thanks, Melvin. So my personal experience with AV and ADT has been to treat them for up to about 6 months, especially in those patients with no positive, still local regional disease, in the hope that they get a good response and whatever radiation dose that we give to the pelvis and the prostate will achieve a greater effect. Yeah.
No, I agree. I think it's for these patients, we're really looking at the long game here, right? I think there was a very interesting comment that was made by Noel Clark actually at the recent USCO. So a lot of these cases were presented. I think one question that was posed to him was in the Stampede trial, if you look at the abiraterone plus ADT and the RT arm, it's a pretty impressive, like almost near sort of flat line. So one question that was asked was how many of these patients actually eventually go back onto RB, because it for the majority of patients is for a fixed duration of 2 years. And by his recollection, it's about 1 out of 5, which means 4 out of 5 patients actually get sustained control. So I think what it tells us is that perhaps defining the optimal duration, because again, we know that even at 1 year, 1 year and a half, your patients kind of struggle through it. So if you imagine adding on a new agent, they become even more profoundly castrated, right? That we need to define the sweet spot in terms of these combined agents, but we might potentially cure some of these patients where they may not actually need to go on second-line therapy.
Okay, thanks a lot, Melvin. Any other questions for the speakers? Okay, if not, I think I have one last question for Dr. Jeffrey Tuan. So Dr. Tuan, we talked about SBRT directed to the prostate. Have you had any experience treating the pelvis together? And if so, what are the dose fractionation you will consider? And are there any practical, would you treat treat the patients in the same way as primary prostate treatment.
I would like Melvin answer this question because he has treated patients like that. But we can definitely treat both prostate, SV, as well as pelvic lymph nodes in 5 fractions. And the fractionation that we use has been 25-in-5. That's been used very much for the rectal cancers. There is a trial that's going on in Canada that actually investigates this now. So far, we await for the final results of that trial. But I think that is technically feasible. There's some technicalities that we need to look at, like in terms of matching, in terms of whether or not you use FFF and so forth. But I'll just save some time for Melvin because he actually has personal experience treating these patients.
Thanks, Jeff. But I think the main issue here is actually the treatment time is a lot longer. So you kind of have to be comfortable. Of course, if you have intrafraction tracking, then it may not be too bad. But I think we can still sort of get by in about 4 to 5 minutes if you're quick in terms of your matching, because they for such a large field, they can't use triple F, right? So it really prolongs treatment time. Yeah. But overall, it seems to be quite well tolerated. Likewise to the Saturn trial, which is the trial that Jeffrey was referring to. So I don't think with the pelvic radiation field, we are actually increasing acute toxicities at least.
Okay. With that, I would like to thank the organizers for organizing the webinar and the 3 speakers for their excellent talk. It's coming to 6:30. I would like to draw the webinar to a close. Thank you everyone for your participation and have a good evening. Thank you.
Should we have a group photo, please, first, before we leave the meeting for everyone in the panel room, please?
Right. Dearest professors and doctors, I shall be assisting in the picture taking session. Please, I will take a picture after the 3rd count. Please stay still for an additional 1 to 2 seconds, just so we can get a clear picture of everyone. Right? 3, 2, 1. Cheese. Another one. 3, 2, 1. Cheese. Right. Thank you very much.
Thank you. Thank you. Bye-bye.
Thank you.
Thanks.
Thank you.
Bye.
Bye.
Thanks. Bye.
Bye. Thank you.
Thank you. Bye. Bye, Dr. Renata.
Bye, Dr. Nagata. Bye, Dr. Miriam.
Bye, Maya. Bye, Mjai. Dr. Bashista.
Bye, Miriam. Bye, Dr. Nagata. Bye.
Okay.
Bye, Dr. Bashista.
Yes, I have.
Bye, Dr. Bashista. Thank you.
I've not listened previously. नहीं